Hey everybody, this is Dr. Michael Richman, and I'm with my great friend and colleague, Dr. Fiorillo.
Good afternoon, everyone.
And today, the topic of our podcast is we're going to talk about cancer in general and screening. And to me, out of everything we've done, and maybe everything we will do, this is the most consequential podcast. So, personally, I don't care if you watch, but I want you to listen, and you can take out a piece of paper and write it down the old-fashioned way. Um, because I think what we're going to tell you today may save your life. And it's that important because there really is no one place to go to for your answers with cancer screening. Don't you agree, Mike?
I do agree. And, I cannot imagine there's anyone that doesn't know someone that has been affected by cancer. It's just impossible.
Right.
And it's more and more common and we're picking up more. So this is really, it's such an in-depth, we could do 10 podcasts on this, but what we're going to try and do is cover the basics. So when people say, hey, what should I be doing? Like that's the theme of everything we've been doing. We're trying to give you information of what should you be doing at a minimum.
Right.
We're not going to go into detail. Obviously if you have an issue or you're really high risk, then yes, you need to see someone, not listen to us.
Right. And we're gonna, like you said, we're gonna do, deep dives into certain topics. But as in our last podcast, I gave you the figures. I'll give you figures again. So in 2024, there were just over 2 million new cases. So that's the incidence. Incidence is how many cases are diagnosed. You'll see also the word prevalence. Prevalence means people who are alive with something. So it's the difference between incidence. And then there were 611,000 deaths in 2024, according to the American Cancer Society. So cancer is the number 2 killer. Heart disease still has it beat, by a long shot. But it's still, and we're all scared of getting cancer. And, I'm scared. And, I know Mike is. He and I talk about it every single day. But what we want you to know is, tell him the age.
I was just going to say, so as many of you may or may not know, the average age, and this is just general, but in all cancers, the average age that someone gets cancer is 66 years old. So it is a disease of old age.
Correct.
In general, it's a disease of old age.
It is.
Pediatric.
No, but it is, when we were talking, all the stuff that you hear, all the nonsense, and Mike can expand on this: diet, people who are in airplanes a lot, radon,
Smokers.
Whatever you want to go to. It's a multifactorial disease. In other words, all this stuff, the hormones in foods, stuff, but it's a multifactorial disease. And the common denominator at the end of the day is our body. We've evolved, through, millions of years. And that's why we have an immune system. And, we have cells in our body that do surveillance. And as you get older, due to all these processes, the immune system, we get mutations in our DNA, and they're not as capable as they were when you were younger of detecting abnormalities. And that's really what cancer is. So, when you hear all these nut jobs, all these nuts, I call them, who are saying, oh, eat this diet to prevent cancer. Mike and I freak out about it all the time.
I'm tired of arguing with people online. There's this whole new push that it's you eat, and it's 90% of your diet and lifestyle, and it's not. Now I don't know what percent it is, but I don't think it's 90% personally. It's multifactorial, right? We know about genes that
It's not even close. It's not even close to 90%.
Right.
Like I said,
we know.
Let's look at it this way. Mike and I, before he became a plastic surgeon, I became a heart surgeon, thoracic surgeon. We did general surgery. Okay. Everybody's always worried about, pancreatic cancer or this or colorectal. Don't you think we would know? And that's what you need to think to yourself. Like when you hear about a family member, a friend dying of pancreatic cancer, oh, but they were a gastroenterologist too. Don't you think if there was the answer, like they would know, because that's the disease that they treat? where the reason I take like a statin with heart disease is because that is treatable and that is by and large preventable. Okay. But when it comes to cancer, yes, there's certain things. Smoking, you don't want to smoke. Okay. Things like that. You don't want to drink a ton of alcohol where there's definite like causation that has been shown.
Yeah, but right. And then how do you explain pediatric cancer and young people getting cancer with no genes, like, a young woman who's not BRCA, positive getting breast cancer. So there's certainly environmental aspects to it, of course, which include diet, and there's genetic components. So it's multifactorial. It's impossible to say what. We do know certain exposures to certain environmental things cause certain cancers. Correct. But in general, what we want to go over today is an average risk person. So if you're high risk, this is probably too basic for you. If you're high risk, you need to be seeing a specialist and do what you need to do. And we'll talk about that. And high risk, like we talked about, is exposure to something like you're a smoker. So you have to get it, for lung cancer, correct? If down in 9/11, right, there's you're higher risk for certain blood, leukemia.
Well, no, it's all that they're saying all different types of cancers.
Correct. So in other words, and if you have someone, a first degree relative would say like breast cancer, you're high risk. So prostate cancer. So there's certain things that we know are high risk today. Right. And we'll mention that we're going to go through average risk.
Right. So I want to mention one thing first of all. So Mike has a subset of neurotic male friends who will spend any amount of money to have any test possible. Okay. And I want to say something first about testing. So 60% of testing, all testing, whether it's blood, x-rays, anything, is unnecessary. Okay. The American College of Radiology says that 30% of radiologic tests are unnecessary. So understand, you may want something, but it's not indicated or it's not right. Okay.
Unless you're high risk.
Right. And there's risks. Okay. And there's risks, with anything. And just because you want it doesn't mean it's right. Okay.
And we talked about, if you missed it, our last podcast, which we talked about MRI screening. And it could be the same for CAT scan, but CAT scan, you have also radiation to think about.
Right.
But just going in with no family history and no high risk exposure to anything and just saying, give me a total body scan. We talked about that on our last podcast. So just beware of those too.
Right. Exactly.
All right. So Dr. Richman, tell me, 2024, 5 most cancers in men.
Well, we can talk about common. I like to think, in terms of fatal, because ultimately,
we can talk
common, but so the 3 most common fatal cancers in men are lung, second prostate. Prostate kills, approximately 35,000 men a year. Yep. Third colorectal, fourth pancreatic. In women, it's again lung. Okay. Second is breast, third is colorectal. But if you want to talk common in women, breast cancer now is more common than lung cancer, but lung cancer kills more people.
Right.
Okay.
Right. So let's talk about this, and let's kind of go from the head down, right? Yeah. Right. So let's start there.
Love that.
Yeah. Let's start there and just say, for an average risk person, what should you be thinking about? So let's start with the head. Okay. So, to me, we can start with oral pharyngeal cancer.
Right. So let's make a comment first about, and then I think it'll be a nice segue into the HPV vaccine, and then we'll get back to it. So 71% of oral pharyngeal, so that's tongue, lip, tonsil, anything in the mouth area, 71% is HPV related. Okay. So really, if you want the younger kids today are certainly at a way bigger advantage than we are, because there's a vaccine, which we'll talk about in 1 second, to prevent it. Okay. So 71% of oral pharyngeal cancers are HPV related. So if you have a sore in your mouth that's not healing, if you have a painless. Well, adenopathy means swollen lymph nodes. But if you have either a bunch of lymph nodes on both sides of your neck and they're painless, we start to think like metastatic disease, Hodgkin's disease, non-Hodgkin's disease. But if you have a single lymph node that's enlarged, you need to see somebody. Short of, yes, if you have a toothache or you have, strep throat and you have enlarged lymph nodes, those by and large, so a non-healing mouth ulcer, you need to think about it. So, getting to HPV, because a lot of people have vaccine issues now. That is one vaccine that I think is mandatory. And, we'll give you the guidelines. Remember, fortunately, 80 to 90% of HPV infections are cleared by your body, by your immune system within 1 to 2 years. So just because you might have had HPV in the past doesn't mean you have it now. But the point is, really, it's almost, I'm not going to say 100%, but it's really preventable. So the guidelines say that the shot should be given starting in 11 and 12-year-olds, that's boys and girls.
And I gave it to all 4 of my kids, and that's one that I would not skip. And like you said, I know today a lot of people are vaccine phobic, but that's one I wouldn't skip because that right there is preventable. It's going to prevent diseases.
Yeah, it's really, if you think about it, HPV-related cancers, like I said, are not 100% preventable, but most cancers are not preventable. That's it. And the key is you got to get them the vaccine early, before they become sexually active.
Correct.
Okay.
That's why they say starting at 11.
Right. And yes, it's been tested against placebos. So for adults, basically, while it has been approved for everybody under 45 in the United States, it's not recommended. So once you're over 27 years old, it's really not recommended, except if you're in the healthcare field and you're having occupational exposure and you're above 27, because, it's you got to look at risk benefits. If you're over 27, you've probably engaged in
been exposed.
Yeah, exactly.
And they're still studying it in the older age population, older than 45. There's ongoing studies. Right. But I would say before kids are sexually active, get them the vaccine.
Right. I mean, because we're going to talk about, pap smear in a second, but by and large, the majority of cervical cancers, HPV, anal cancer died of HPV. So, penile cancer, which is very rare, HPV, related. So big deal. Okay. So that's nasopharyngeal.
Fairly deadly oropharyngeal cancer. So
bad.
Yeah.
Bad.
Yeah. You don't want that.
And the surgery is disfiguring, horribly disfiguring.
Yeah. It's not, it's terrible.
All right. So let's move on next to thyroid.
Yep. Thyroid. So most of these can be picked up by exam, feeling nodule on the thyroid.
Mm-hmm. So we're most worried if you have multiple nodules, which is called a multinodular goiter. Mm-hmm. It's benign. Okay, chances are it's benign. If you have a single solitary nodule, yes, you can talk to your family practice physician or your internist, but if they blow you off, I would see an endocrinologist or an endocrine surgeon, because once it reaches a certain size, you need a needle-directed biopsy.
Yeah, or head, neck, or ENT.
Right. Well, first you need an ultrasound. Okay, ultrasound's mandatory, and then you need an ultrasound-guided biopsy. And remember, by and large, even with more advanced, there's 4 types of thyroid cancer. We don't need to get into them, but with the 2 most common, even with more advanced disease, they're curable, not treatable, curable.
So out of all the ones we talk about today, that's probably the one you want if you got any.
Yeah.
Okay.
You don't want it, but you got it. So, right. Okay, so that's thyroid.
And then moving down will be your specialty, right? So we'll talk about lung and esophagus. So I'll let you do the honors there.
So let's talk about lung cancer. So we're going to have on at some point a very close friend of mine who's head of lung cancer oncology, medical oncology at UCLA, seeing increased number of cases in younger women who don't smoke. So that's a subset that we need to talk about. But chest X-ray, nothing. If anybody ever wants to take a chest X-ray of you, just thank them. not recommend show anything. And by the time it shows a nodule, you're in deep trouble. So guidelines say now to have annual low dose CT scanning of your chest. And I said annually, so every year. If you're over 50 and you've smoked greater than 20 pack years, so in other words, 20 years of smoking, okay, annually, and we're picking it up early and it is making a difference. People are surviving, okay, because by and large the 4-year survival the 5-year survival of stage 4 lung cancer is anywhere between 10 and 15%. And it's, yes, it is getting better, but it's still the number one killer of men and women. So short of, yes, if you have a persistent cough or you're coughing up bloody sputum, by all means, don't wait. Okay. But in terms of if you're a smoker, that's what you need to do. If you're a non-smoker, it is what it is. Like I said, there's no magic. You have anything to add?
No, I mean, I think you hit the nail on the head, and it seems to be more common, right?
Yeah, and getting more cases, and we talk about radon exposure. Really, like in California, we don't have basements, so unless you lived in your parents' basement, and the chances of radon being a significant contributor is not a real
Well, I think
thing.
higher and also in certain parts of the country, and
Right.
if your house is built in like in a mountain or
Or in the Midwest, where everybody has basements. But by and large, it is a disease, of smokers. And secondhand smoke is significant, regardless of what people tell you. It is significant. The next thing, which is a wicked cancer, is esophageal cancer. So there's two kinds. The kind that is associated with reflux disease, GERD, as most of you know, is becoming more common and is now the most common in the United States. The upper part of the esophagus, which is a different kind of cancer, is associated in smokers and alcoholics.
Right.
But the issue is people who have a history of gastroesophageal reflux. And as I said in an earlier podcast, there's a parallel rise. So people who've been on proton pump inhibitors, we're seeing a higher incidence of adenocarcinoma. It's called the esophagus, or where the stomach meets the esophagus. And why is that? Well, because the ow part, which is what alerts you to it, is being nullified by the proton pump inhibitor, the Nexium, the Prolosic, or the old time drugs, Pepsid or Tagamet. But you still have it going on, which is the bile part of your acid. Okay. So you're neutralizing the acid. So if you have a history of reflux, and when I say history, burning, not just one time, but burning or regurgitation, vomiting, gets worse at night when you're laying down, please, you need to get an endoscopy.
Yep.
Because esophageal cancer, before it becomes esophageal cancer, it becomes something called Barrett's esophagus. So it's a progression. And if you have an endoscopy and they see you have Barrett's, there's something we can do about it. But don't wait. Millions of people are on proton pump inhibitors and, quote, they're fine. Their doctor told them they're fine. They're not fine. You need an endoscopy.
Yeah. And I also think people are better about getting the colonoscopy than the endoscopy, because for some reason there's more talk about it. I got to get your colonoscopy and at 40.
Yeah.
And people do. People are good about that. So I think if you're going for your colonoscopy and you have any sort of reflux at all, you're under anesthesia anyway, right? A little sedation, up or done at the same time.
Most good GI guys, like your brother, he would say, listen, we're going to do an endoscopy at the same time.
Exactly. So if you have any history of it, for sure. And that's a good one. And people don't think of that one at all. So that's a good one. And a lot of people just live with reflux. I got heartburn. Let me pop something. They don't think that was cancer. So
and esophageal cancer, by and large, it's discovered stage 3 or stage 4.
Yes.
And and it's too late. The only time we save people with esophageal cancer is really early, and it's a big, big operation. Like that's one of the cancers, just like pancreatic cancer. We used to say in surgery, we still do, as Mike knows, the chance to cut is a chance to cure. And esophageal cancer is one of those, but it takes a big, big surgery early on in order to save somebody's life. Okay, so next let's move on to breast cancer. Mike's going to talk about that, which mammography.
Yeah, of course. So everyone, knows about this, right? Most common cancer in women. So two subsets: family history, no family history. So with no family history, there's some mixed guidelines. We always used to say 40, and there's also 45, and now some are 50. And that's really much of because of insurance, right? So it depends on what your insurance will cover. But I like to go at 40. I like to stay at 40. I don't know if it's always going to be covered. It depends on Victor, and also your insurance, I believe. But
no, they'll cover 40, and the argument that they get into
they're stopping doing that, though. I've had some people not being covered until they're 50.
Yeah, I mean, I haven't had that experience, but what you need to do is there's several guidelines there. The American College of Radiology, the mammography, who are board certified mammographers, I would look to them, because a lot of these guidelines are made by what's called the U.S. Preventative Task Force. Not a fan, wish they would be disbanded, because, for example, the breast cancer guidelines made by them. So they're a volunteer group, essentially the government, but they're family practice, internists, OBGYN, epidemiologists, and nurse practitioners. There's not one breast surgeon on it or breast oncologist who looks at the evidence and makes recommendations for the masses. Okay. And to me, it's unacceptable.
Well, the common guidelines are basically 45 without family history, 40 with a family history. So that's kind of what we go by. I mean, I order, probably 50 mammograms a month, right? So I know. But I will say, it's interesting, right? So when I started, I used to get a mammogram on everybody. And the reason I did that, and I'm talking about even like young girls in their 20s, and the reason I did that was because I wanted you to have a roadmap of the breast before I either put an implant in, or I did a lift, or I did a reduction, or whatever I was doing, because it'll change things around. And then if you have a mammogram later on, just say you're like 35 and I get a mammo, and then you get one at 40, you could at least compare and have something to compare. I stopped doing that since, but I picked up a fair amount of breast cancer, believe it or not, in women under 40. And one case I had, which I always remember till this day, was I had a girl probably in her late 30s, and she refused. She did not want it. And I said, well, I'm not going to do the surgery then. I was pretty stuck to that at that time. I since changed. So she begrudgingly went and had a mammogram, and she had breast cancer, and was cured from it. So
and she had no family history.
No family history. Right. So it's definitely, and me and Mike go back and forth all the time, right? So about these unnecessary.
But let's remind everybody, we're talking about average risk.
I'm talking about average risk, but I'm also talking about someone that I was operating on. So it's not just a random person. I said, go get a mammo. Right. There's someone that I was going to change around their architecture of their breast. So I felt, and a lot of people did, it wasn't just me, that it was good to have a baseline mammo before any surgery. Since then, no one really does it that I know of. So I stick to the guidelines now, but it's just anecdotal that I like to throw in there. But basically, family history 40, no family history 45. And that's what I'm going by right now.
Well, I'm gonna. Then there's one other group of people. So the National Cancer Institute says that you can do 30 years of age or before if you have a family history of somebody with breast cancer who was diagnosed before they were 30. Okay, so really young, or somebody who is a first degree relative with BRCA1 or BRCA2, or you have BRCA. Okay, it is acceptable in that case to start before you're 30. Or if there are kids who've had radiation for various reasons,
Right.
had childhood
Yes.
cancers. So if you've had radiation between the ages of 10 to 30 years of age, there definitely is a subgroup of population who should probably get a mammography at 30 years of age. But these are a separate case. This is a separate group of people, who are high risk. But your average risk is exactly right. 45
And
or 40,
and if
depending.
you have a relative, first degree relative, has a history of it, you need to talk to your doctor about when to get these tests, but also about genetic counseling.
Yes.
You want to go for genetic counseling, and you want to get, BRCA1, BRCA2, which is a simple blood test, gene test. So, and then you can, discuss prophylactic, mastectomies and stuff like that. But what I would say is family history does change the dynamic. So with a family history, you want to go for counseling. Either way, I would go.
Correct. Correct.
All right.
Okay. So we good with
Yep.
mammo, and we'll move
yeah.
down. So let's move down into the abdomen. So unfortunately, there's no good screening for your stomach unless you have an endoscopy for liver and gallbladder and bile duct cancers. Liver cancer is way more common in the Far East and in Asia, extremely common, and bile duct cancer. But by and large, short of having hepatitis B or hepatitis C or being an alcoholic with cirrhosis, the likelihood of you getting liver cancer is very low. However, if you do have one of those three, yes, you should talk to a gastroenterologist and figure it out. Maybe you should have an ultrasound of your right upper quadrant and image it, because those are three risk factors for liver cancer. Major risk factors for liver cancer. I know we're all scared about pancreatic cancer, but just like esophageal cancer, pancreatic cancer is still considered a rare disease. It's 63,000 new cases diagnosed. Yes, it's a wicked cancer like esophageal cancer, but that's not a lot of cases. It's just, it takes on increased meaning because when a celebrity or somebody's diagnosed with pancreatic cancer, it's a big deal.
And
What are your thoughts?
it's also late stage. I feel like the symptom.
Yeah.
By the time it's diagnosed, it's usually pain, and people ignore it. I mean, how many times do you have stomach pain? Right? We all get stomach pain, and a lot of people just deal with it, and they think it might be gas or whatever. They ate something or hunger pains, and by the time they get it checked out, it's stage 3 or stage 4, and that's why it's so virulent. And then you look,
Right.
you look,
And, that's why we talked about in our last podcast, why whole body MRI, people are so worried about pancreatic cancer, but by and large, it's missing really, really small early stage pancreatic cancer. So at the end of the day, it's just a game of your odds, but there's not a lot of cases. I mean, believe me, there's way more important things that you should be worrying about than are you going to get pancreatic cancer. Don't you agree?
yeah. Listen, you don't want to get any cancer, but I think pancreatic scares the hell out of all of us because we're thinking like, shit, you get that diagnosis and you're basically saying goodbye to everyone. So it's scary, but fortunately, it's on the lower end. Right, it's not even on the list of the top 5 for men or women. But
Right.
Okay. So don't ignore symptoms, GI symptoms.
Right. Okay. So moving down, kidneys, there's no screening, but usually when you have your annual labs every year, they do a urinalysis. If you have blood in your urine, microscopic blood, they may want to follow up with that. But it's usually what's called painless heme. In other words, blood in your urine,
Blood urine.
without pain. But again, kidney cancer is not that common. Okay, so you don't really have to worry about that. And now we'll move on to colorectal. Just one word. So we talked about Cologuard in our last podcast. Cologuard is accepted by every society. It is for somebody who is average risk, has no family history, or has no conditions like ulcerative colitis. or some familial polyp syndrome or had multiple polyps. But for somebody who's average risk, it is a very good screening test every 3 years. But short of that, the gold standard still is colonoscopy. So why don't you talk a little bit about that?
Yeah. So, having my brother being a GI doc, we've talked about this a lot. He's seeing younger and younger people with colon cancer, and the screening has lowered too, right? So now they're talking about 45. He even thinks 40. So,
Right.
should be the age. And this is one that has a high cure rate if you find it early. So if you go in and find it early, you can beat it. So this is something that you need screening. So I don't know, how many people know that, Vince Lombardi's story, right? But really, they trophy what team wins the Super Bowl, famous football coach, right? And that's the famous story with him. He ignored it. Doctor wanted him to get a colonoscopy. And he said, "You're not sticking that thing up my butt." That was all famous thing. And he could do it. And then by the time he finally had to do it because he just was completely, shut down, it was stage 4 and he died shortly after. So we like to think that, he would have lived to be an old man. So that's one that we all know. So I think fortunately that's not missed. Although I do have people that think the same thing. I'm not getting that thing stuck in me and so we have Cologuard, which will help.
Right.
And I would not put it off. So don't put it off.
I mean, we're the worst patients, doctors, and we don't practice what we preach. So I just recently had a colonoscopy. I did have 2 Cologuards before, but I waited a long time. And, with all candor, the reason was because I didn't want to know. It's really hard when you're a doctor that treats these diseases, and I still treat cancer, see so
People
much.
want to take the day off and they think the prep is
Well, you just also don't want to know that, there's a part of you that's like fearful. Just a comment about diet. I just wanted to add in. So it's funny that in Asia, upper GI cancers, esophageal and stomach are extremely common. Colon cancer, in the United States, it's just the opposite. Colon cancer is more common we think, a lot of the experts, I think after talking that it is related to diet, it is related to that we're injecting so many things, antibiotics and hormones and whatnot. But it's just an interesting phenomenon because, in Asia, they're more fish eaters, and we're more, meat eaters. And clearly, there's an association, not causation, but an association with the Western diet and colorectal cancer.
Yeah. And what about fiber too, right? I don't think most of us without taking a fiber supplement get enough fiber in our bodies.
Right. Exactly. So colorectal cancer, average age, average risk 45, high risk less than 40. But again, stress, these are guidelines and recommendations. Okay. Recommendations and guidelines. So that doesn't mean everybody needs to be individualized.
Correct.
Okay. But, and that's what you need to remember is you're a person. If you have any concerns, you go see somebody that is board certified. And we'll talk about quickly at the end about that. Who should you see for everything? Okay.
And the other thing too is, don't be afraid of it. It's not that bad. I know that people just don't want to do it. And that's one I think they put off. Right. And then next, I think we move on to prostate.
Well, prostate and then, pap smears. You can mention pap smears.
Yeah. And but so let's go through prostate because that's another one that is common.
Yeah. So prostate, I have some tremendous issues, as I said, so I personally believe that every man, this is my own personal belief, starting at 35 or 40, maybe even 35, should have a PSA, which is a blood test. Now, why is that? Everything we've told you so far is an invasive test, and there's risks. A freaking $2 blood test, 0 risk.
Yeah.
Okay. So, PSA. So, the argument that the U.S. Preventative Task Force, who I told you I don't like, they're much more strict than the American Urologic Association. They say that PSA is unnecessary because it leads to further downstream testing. Okay.
Well, there's a high false positive.
Right. Right. Okay. But let me just tell you, um, so if there's 10 deaths, 20 deaths, 100, 1,000, there's 35,000 men that die of prostate cancer. Okay. Number 2 killer of men. So I don't want to hear any shit from anybody, excuse me, that I'm going to, not get, that it's going to lead to further downstream testing. So, basically the guidelines say that you should probably get it regular screening at 50 to 55. I don't buy it.
Yeah, they have to change that. I mean, I've been getting it forever. Like you say, whenever you get blood work, we all get blood work, right? Once a year, hopefully. Just get a PSA if you're a guy. Right. It's not a big deal. It's an easy test to get.
Right.
And, but the guidelines do say 50, and then with a history 40. But
right, and what's even stupider is that they recommend that anybody over 70, and you're like, does not need it unless their estimated lifespan is greater than 10 to 15 years. So you're like, it's crazy. So you're 70 and you're like,
yeah,
am I gonna
live?
Right? Am I gonna live more than? Am I gonna make it to 80 or 85? If I am, then maybe it's necessary, maybe it's not. So
Well, the average,
that's
the average age of getting prostate cancer, I think, is late 60s anyway.
right.
67, 68. So, just get the PSA, and then if you get your annual physical, they can pick it up on a rectal exam too, potentially, but that's more unlikely. We get the PSA. If the PSA is elevated, then you need further workup. And
I mean, I've never felt one on a rectal exam. My fingers weren't that long, but that was a joke.
Yeah, for sure.
But it's you get a PSA. Does it lead to a biopsy? No, absolutely not. Because my dad died of a type of blood cancer, but his PSA was 18, and I sent him to USC. I have a fondness for, that's where I do my general surgery, but they have the finest urology program, I think, in the United States. And they were able to actually milk prostatic fluid and do circulating tumor DNA on his prostatic fluid. And he did not have cancer, and he did not have he did not need a prostate biopsy. And, I know Mike has other friends that we talked about in whole body MRI that, guys are having it done in the Prenovo and stuff because they're looking for prostate cancer. And it does not, that specific test, whole body MRIs, does not find early prostate cancers. You have to have a special MRI, just like when you have a breast MRI. Let's say you have a mammogram, dense breasts, and they're like, oh, you need an MRI afterwards. It's a special MRI.
Special not prostate, correct?
Right. So,
but I believe that's very sensitive. So I do know one person in particular that does do that every other year to make himself, sleep better. I guess he's got a family history of it, and he doesn't want to rely on the PSA. So.
Okay, that's being a little neurotic. No, no urologist. Certainly your insurance is not going to pay for it, but right. No urologist is going to say, so, recommendations are, as Mike said, screening 45 to 70. If you're less than 40, you should have it done if you have a family history of it, or if you're African American, okay, because they're higher risk. But like I said, it's a blood test. Who cares?
Got it.
Okay. Quick mention of Pap smear.
Yeah. So every 3 years, they say starting at 21 is the recommendation. And then I believe it's 21 to 49. And then from 50 and above every 3 years with HPV as well.
I did not know that. That's interesting.
Yeah. And most women I know get it every year, because they're up there anyway, and most people feel like so. I do think that, even if it's covered or not, I do think most women do it every year. But the guidelines are every 3 years.
Right.
And like we said, these are general guidelines. I have no problem with if a woman wants to do it every year.
Right. I mean, I feel really strongly, ovarian cancer, wicked. Okay. And unless they're doing something else, it's usually picked up in advanced stage, and your ovaries sit in your pelvis and in your abdomen. I kind of feel that if you're having a hysterectomy in your 30s, and this is just my own personal belief, and I'll explain to you why. If you're having a hysterectomy in your 30s, okay, like late 30s, have your ovaries taken out, because yes, you're going to go into menopause early, and I know it's frustrating and all that, but ovarian cancer is 100% preventable. Okay. And certainly if you're in menopause or perimenopausal and you're having um, a hysterectomy, have them take your ovaries out. Now,
They usually do.
Right. And if you're one of those people that does have ovaries and had a hysterectomy, or you're still an intact female, that sounds like a dog. But if you're an intact female, I strongly believe that you should have a transvaginal ultrasound every year when you go to your doctor's office. They do it in the office. You don't have to go to another place. A transvaginal ultrasound, because if you have an abdominal ultrasound, you can't see the ovaries well, but a transvaginal ultrasound will pick up an ovarian tumor. And to me, again, it's non-invasive. And somebody may tell you it's not necessary, but boy, ovarian cancer is bad news. And, if you can do an ultrasound. So that's that. And then let's talk about skin.
So skin, skin seems to be pretty straightforward, right? So go for your yearly screening. Most insurance plans cover a yearly screening, and your dermatologist can do that. And besides that, be your own advocate with that, right? So examine anything looks suspicious at all. Go in. Now, there's all these apps you can use to not make your diagnosis, but at least, raise up your radar to something. And then there's some apps you can put it in. I'm sure AI that eventually be able to diagnose all this stuff for you. But if something looks suspicious, and you can find out by just looking online, go in, get it checked, get it biopsied. Most dermatologists will have a low threshold for biopsying stuff. And this is one that also is very preventable. If you can get a melanoma, or first, if you can get basal cell or squamous cell, which are benign anyway.
Well, squamous could be nasty.
Squamous could be nasty, but if you get to these things early, 100% curable, right? Basal cell, squamous. Melanoma, you need to get to it early, because if it's thin, most we catch early. They're in situ, which means it has not spread beyond the skin layers, or very superficial skin. You're cured. We get it out, you're done. If they get deeper, then you start needing, lymph node biopsies. And then when it gets to a late stage, you don't want that. That's bad.
Right.
So this is something 100% that you could cure. So this is one.
Right. With early, also remember,
early intervention here.
A lot of people don't realize a lot of the fatal melanomas are in places that you wouldn't think. So under the fingernails. Okay. If you have like a mole under your fingernail, or on the sole of your feet. Okay. I'm not, just weird things, but
Be done there. Yeah, correct.
Right. So I guess that wraps up, our cancer and our cancer screening. I just want to make a few comments. First of all, the main thing is, so what do you do if you get a new cancer diagnosis or pre-cancer diagnosis? And I think, I always tell people that the most important thing you can do is to pick out the right place to go. And, you need to remember, you're going to the doctor, not to the hospital. But if you're in a place where you don't have a lot of choices, you always know you're going to get the standard of care and the right care if you go to a university that has a medical school. I tell people to try and go to one of the National Cancer Institute approved cancer centers, and there's 72 of them that are in 36 states in the District of Columbia. But, some states there's not a medical school. So, you can always do an opinion on the phone with a doctor at a medical center. And, at least you need to see a specialist, which is, most people don't know why, they don't know what to do. And, I have doctor friends who have the same problem, and which is why I started my company, Paladin MDs, because of advocacy and guidance. People need a quarterback to get them through a problem like this. So, generally the best thing is to, again, go to a NCI approved cancer center. You can Google it, or see a specialist. If your family practice doctor, your internist poo-poos it and tells you it's not a big deal, I wouldn't accept that as an answer. Especially if something is precancerous. If it's cancer, you definitely need to see a specialist. And then one of my rules is called Michael Richman rule of testing is, here's how you know if a test is unnecessary. If the positive result and the negative result, the outcome is no different. In other words, you're not going to do anything different, whether it's positive or negative, then it's an unnecessary test. So with that, I enjoyed speaking to everybody today. I hope everybody learned a lot from Mike and I. I really enjoyed this. And without further ado, let's just say goodbye, and I hope you have a great day.
Hey, before we go, let's just recap. So what I want to say is if you have a history of a certain type of cancer in your family, or if you're high risk because you drink or smoke or have some other exposure, you should go see somebody and get, professional advice on how to prevent stuff and how to find stuff. But if you're an average person and you're just listening to the podcast, what I would say is don't ignore any symptoms. Do the best to auto-surveil yourself as much as you can. Also, go once a year for your checkups and stuff, and just stay on top of it. Early diagnosis is the key here, as we all know. So that was great, and let's wrap it up. And I'm looking forward to the next time. And just remember, when it comes to your health, the truth matters.
Okay, so thanks, Mike. I enjoyed doing this with you today. Thought it was a great show. I hope we helped a lot of people and saved some lives. So
I agree. If we could save one life, that would be we'd be doing our job. So until next time, when it comes to your health, the truth matters.